Can anyone hear me? John, you hear me?
Hear you, Bill. Bill, I'm here. We hear you.
Oh, there you are. Okay. Let me know when you're ready to start, Brenda.
Okay. Bill, they are streaming live on Spectrum on the new county station, CCNC TV, on the county website and on Spectrum Channel 5. They are asking that anyone that's not speaking to please mute. And if someone forgets, Angela can also mute everyone. And so you'll have to unmute when you're speaking. So with that, Bill, it's I got 2 after 1. We'll get started. We're ready.
Okay. At this time, we'll call the meeting to order. Board members, you have a copy of the draft agenda in your packets. Do you have a motion to approve the agenda?
I make a motion we approve the agenda.
Second.
It's been moved and seconded that the agenda be approved. All in favor say aye.
Aye. Aye.
Opposed?
Aye.
Motion is carried. Moving on to the consent items. You also have in your packet the regular minutes from our January 27th meeting. If you've had a chance to look at those, I will also entertain a motion to approve them at this time.
I move we approve the minute.
I second.
It's been moved and seconded that the minutes from the January 27th meeting be approved. All in favor say aye.
Aye.
Any
Aye.
opposed? Any opposed? No. Motion is carried. Okay, board comments. Does any member want to make any opening board comments at this time? If not, then, Brenda, I'm going to turn it over to you as we move into our guest discussions.
Great. Thank you, board members. This afternoon, we are excited to have with us members from Alliance Health and North Carolina Department of Health and Human Services, Division of Mental Health, and members of the Alliance Board who are Cumberland County representatives. As you know, we have had lots of discussion regarding children and adults with chronic and complex behavioral health needs and the need for therapeutic residential services. That's been a major challenge for us as it relates to both children, foster children, and our disabled adults. I want to thank the board for your support. And as you've heard many times about the challenges we've had with placement of these children and having appropriate placement of these children and adults. You asked board members that we invite Alliance Health and the Division of Mental Health to join us and share with you what we've been working on as it relates to this issue. I want to put big kudos out to Alliance Health. We meet with Alliance Health. They're our LME MCO, and we have been meeting and have a long and rich relationship. We meet at least quarterly, but we talk quite often about just the challenges that our citizens face as it relates to behavioral health needs. Our Division of Mental Health has been part of these conversations and really appreciate them coming to the table to try to figure out how to best serve these citizens. And then to our Cumberland County representatives on the Alliance Board, Dwayne Holder, our Deputy County Manager, and you all know Dwayne, he's always at our board meetings and a great support of the work that we do. We also have Miss Lotus Gloston with us as well, and she was a former county mental health board a member when we had a local county operated mental health system, but she also serves on the Alliance board. And I think she was just reappointed to the Alliance board, and she's been a staunch advocate for citizens with behavioral health needs, and we really appreciate having them. Commissioner Adams couldn't be with us this afternoon. He also serves on the Alliance board, and he has been at the forefront of how to best address the issues and needs of both children and adults. And so he's been a staunch advocate as well. And so I'm going to turn it over to Rob, and Rob Robinson is the CEO of Alliance Health, and he has Sean Schreiber with him, one is his staff, and he'll kind of share with you a little bit about Alliance Health, and he has a PowerPoint presentation to share with you the work we've been doing, especially intensively over these last 4 or 5 months. We also have Victor Armstrong. I think I saw Victor. Victor was with us a minute.
I'm here.
Okay, great. Victor Armstrong is with North Carolina Department of Health and Human Services, and he is Division of Mental Health Director. And I just want to say thank you, Victor. This gentleman is very busy trying to run state mental health and oversee state mental health for the entire state. He's taken time out of his very busy schedule to be very engaged in the issues and helping us strategize around solutions. And so I want to thank Victor for being with us this afternoon, but also board member, want to let you know how engaged he's been in the discussions and the work here locally. With that said, and just in the interest of time, I'm going to turn it over to Rob, and he'll kind of give you an idea kind of what we've been working on.
Thank you, Brenda. Hey, Brenda, Sean's going to share his screen. I think I may have been made the presenter. Is there any way that he can be made the presenter? I'm having some computer stuff here.
Absolutely. Angela, can you help make that happen? Just give us 1 second, everyone.
All right, well, Brenda, you can kick it off.
Okay. Sean, you're the presenter. There we go.
Got it. Perfect. All right. So thank you, Brenda. Thank you for having us. Again, I'm Rob Robinson with Alliance Health. I also have Sean Schreiber with me. He is the Executive Vice President overseeing provider networks and community health and well-being departments. We are definitely glad to be here. As Brenda said, we spent a lot of time in Cumberland DSS trying to work through some of the issues that we had. She had asked that we give an update on our work to address the needs of youth in Cumberland involved with DSS with behavioral health issues. So let me start by saying that we are acutely aware of ongoing issues in serving this population. These issues are not unique to Cumberland. They are prevalent across the state and, quite frankly, across the country. Addressing the needs of this population is not new for us. Since our inception, we have taken steps to expand capacity and offer better services to meet the needs of this unique population. I will be the first to tell you that we are not there yet. In order to achieve our goals, we believe it's going to take a collaborative effort among our two agencies, but also providers, other community stakeholders, as well as the state, if we're going to have a real impact on the issues at hand. I also want to state that I think it's important to note that there are hundreds of kids in DSS across our 4-county region that are being served and being served successfully. However, there is a small subset of kids with very high needs that treatment options are not always readily available. Over the past year, we have been focusing on improving treatment and support for this population. We have developed and are in the midst of implementing a comprehensive plan to address the complex needs of these youth and families, the ones that we're talking about today. We are investing over $15 million in this initiative, and that, of course, is what we want to talk about today. So I'm going to kick it off. I just got one slide giving a brief overview of who Alliance is for those that may not be as familiar. Then I want to give a quick update on some crisis services in Fayetteville. And then I'm going to turn it over to Sean, and he's going to share with you other key components of the plan to help kids in DSS. We'll be sure to leave some time for some questions. Next slide, please. All right, so about Alliance Health. We are the behavioral health LME MCO for serving Durham, Wake, Cumberland, and Johnston counties. The LME stands for Local Management Entity. That is our responsibility for serving folks who are uninsured using state and county dollars. MCO stands for Managed Care Organization, and that's about serving individuals, both children and adults, with Medicaid. As you see, we're responsible for about 470,000 folks who have Medicaid or do not have coverage. About half of that, right now, we're about 260 of those have Medicaid. The big difference between the two service delivery systems, Medicaid is an entitlement. So if someone meets medical necessity, needs the service, we are required to provide it. The state side is there's significantly less funding, and it's more. And the easiest way I describe it, and it's very simplistic, but the easiest way is we do the best that we can with the money that we have. And the folks that are uninsured, underinsured is our biggest challenge every day, trying to figure out what to do with all the folks that are uninsured with very limited resources. We have a staff of over 500. We do have an office here in Fayetteville. I think there's 40 to 50 staff that are stationed over at 7-Eleven Executives Place. Contract provider, we are not a provider of services. We are the manager of services. We contract with well over 2,000 providers, anywhere from people that have that are doing just putting a shingle on their wall with doing outpatient therapy. We also contract with about every hospital in the state to deliver acute or inpatient services. The big shift for us is we're moving to become a Challenger plan. We are very excited about this. This is taking the individuals with the greatest needs in our Fort County. Right now we're responsible for their behavioral health as well as IDD needs. We will, under a Challenger plan, will be responsible for taking care of their physical health as well as their pharmaceutical needs. We are excited about this. We are completely in alignment with the state's vision for this, and we plan to go live July 1st, 2022. And that's probably all that's involved with that is probably a conversation for another time. Next slide, please. All right, Sean, go to the adult crisis one. All right, adult crisis services. So we selected Recovery Innovations to operate the adult crisis facility here in Fayetteville. You may be more familiar with the name Roxy Center. It's located on the campus of Cape Fear Hospital. Before we could fully open it, it required significant renovation to include changes to the layout to better suit the model operated by Recovery Innovation, it's also known as RI. If you are not familiar with the crisis facility, there are two parts to it, chairs and crisis beds. The chairs have been open since the spring. And as you can see from the numbers served keep rising, which of course is a good thing. The chairs are where people in crisis can come and stay up for 24 hours. They can be assessed, triaged, and referred home or to any needed services. The crisis bed, and there are going to be 16 crisis beds, are where folks in crisis can come and stay up to 15 days in a safe and secure environment. Again, the chairs are open. The crisis beds area is currently under renovation, and we actually hope to have the facility fully open sometime in the next month or two. They've set a deadline for the end of March, but with construction stuff, we'll have to see. So I'm going to say within the next couple of months. Next slide. All right, child crisis facility. Good news is that we are back on track with opening the regional child crisis facility. We hope to have this open in the summer of this year. Again, with COVID, there's some construction stuff, so it might be early fall, but we are working as fast as we can to get this open. Next slide. So the Child Crisis Facility has long been a primary component of Alliance's multi-year reinvestment plan. Unfortunately, we were forced to suspend work on renovation of the facility due to continued cuts to our funding over the past several years. Our cuts have equaled almost $70 million and really hampered our ability to improve and expand services. The good news is we haven't had any cuts this year, and we actually got a little bit more money, so we are back on track. Again, if you're not familiar with the Child Crisis Facility, we plan this will be a state-of-the-art facility. It will include 16 crisis residential beds. It will serve youth ages 6 to 17. It will also include behavioral health urgent care services where youth and families can arrive, receive same-day access to a clinical assessment, psychiatric evaluation, and they can also receive any necessary medications that they need. The goal of the program is to stabilize youth in crisis, begin the treatment process, and refer them either to home with a treatment referral, which of course is ideal, or refer them directly to needed out-of-home treatment, such as to residential or inpatient services. I always want to make sure it's clear, the crisis facility is not a destination. It is a short term for people in crisis, get them stabilized and get them to where they need to go. Excuse me. The provider will be Kids Peace. They are a nationally recognized organization for serving youth and families. They were selected by us through a competitive bid process. We are very pleased with our selection at this point, and they are very anxious to get started, as we are, and I'm sure as you are as well. As we get closer to an opening date, we will be sure to create opportunities for you to meet with Kids Peace and to also tour the facility. Next slide, please. All right, so here's the map of where the facility is located. I share this with you. This selection, there's two parts to it. One was we did it in partnership with WakeMed Hospital, but the location was critically important to us. As you can see, it's centrally located to our four county regions. And again, once we get closer, we'll be sure to create some opportunities for you to take a look at it if that's of interest to you. So I'm going to stop there and turn it over to Sean. He's going to talk about the rest of the elements of our plan, and then again we'll be sure to allow some time for questions. Sean, take it away.
All right. Hey, thank you, Rob. Thank you for the invitation, Brenda, to present to you again in the board. And just the work we're going to outline really comes from a lot of hard work and sometimes challenging conversations just to really understand in a deeper level what some of the needs were of children in Cumberland County, particularly those who wind up in Department of Social Services custody. And I think what we came to an understanding is really a couple of needs, and we tried to, the best we could, to come up with a plan to address all those. Some things will be happening faster than others, some will be in development, but what we'd like to do is really today give an overview of the areas we're focusing on, which are really about making sure we're identifying these children early, and as kids are coming to the system, making sure that the behavioral health services they need can be in place to hopefully alleviate some of the need for the more intensive things that come down the road. But we also know there's already kids in the system, and there will always be kids in the system that, despite best efforts at early intervention, are going to need something else. And what we found is a lot of things that are in the behavioral health system today don't necessarily meet some of the evolving needs of youth and some of the timetables that other stakeholders, find themselves in. Historically, the residential system in behavioral health is not meant to be kind of an overnight kind of placement option. It's usually kind of planned. There's typically a lot of interviewing of potential sites by families, and obviously that doesn't work when in the middle of the night there's a crisis and the child's in the ED or a child may be in the custody of the Department of Social Services. potentially sitting in a group home placement that's not appropriate. So we knew we had to develop some short-term options. And then ultimately, we also know we've all kind of worked with these kids for a long time that there's some children that, despite everyone's best efforts, they just need something different. They need really much more thorough evaluation. They need more time and a consistent kind of secure level of care for a more permanent plan to be made. And we also unfortunately know that there's youth at 16 and 17 that the reality of finding kind of a new permanent family is pretty diminished. And I think we certainly see that in our data with kids who come into therapeutic treatment foster care at 16. They're typically until they're adults, as opposed to kids who come in younger who actually do have a transition out. And as I'm going, if you have any questions, please please let me please interrupt me, and I'll be happy to answer. So a couple things we wanted to do is make sure we're doing a better job at identifying youth who are kind of at risk for disrupting care. And one of the things we've noted is that a lot of the children, obviously, when they come into social services, have significant trauma history. And when we've been going back and looking at the behavioral health services and assessments they've seen over years, it's kind of been addressed, but there hasn't been a really comprehensive job addressing kind of in screening and assessing for complex trauma, and then building really strong treatment plans from that. So one of the goals is to implement a much more comprehensive complex trauma assessment. So as a Department of Social Services, maybe take someone into custody and you have alerts that this child, has probably been a victim of some kind of trauma, making sure there's a network of providers who have been trained and skilled in doing this much more comprehensive assessment. We're talking 6 to 8 hours of assessment and making a comprehensive plan. And I think the reason that's so important is if without that, children may get referred to behavioral health services, but may not be referred to the ones that are going to address the whole reason they kind of need services in the first place. So we've done some additional training for 3 local agencies. We've contracted with 3 of the behavioral health entities that are in Cumberland County to provide these comprehensive trauma assessments. The other thing, it's not just a good enough job to have assessments. Then if people identify complex trauma, they have to have the staff to do the specialized therapy. And there are evidence-based models of treatment for kids who have complex trauma. And so, some of the agencies had some training. We're making sure that the agencies who are providing the assessment also go on and have more of their staff trained. There's a group that operates out of the Triangle, and the name is failing me, but providers from around the state go there and get education on certain trauma-based therapy models. And then we're also contracting for the trauma-based therapies. And because these are these therapies take longer to get staff certified with, the sessions need to have longer length, they need to be more frequent. Alliance does pay additional rates and has a kind of a higher rate schedule for the providers to do this to make sure they stay engaged and motivated. The other thing we want to do is that oftentimes when children come into the system, they have lots of needs, and the behavioral health system, at least over the last couple of years, it tends to be a little bit more episodic. So a child may be referred to an outpatient provider. They maybe do okay, but then when they're done with the outpatient provider, they're not really getting much other treatment, even though there could be other needs going on in the background. So what ends up happening is they're kind of discharged from an episode of care, and then maybe a couple months later something else happens, comes into another. So we thought that really one of the things that's been missing in the system has been really more comprehensive case management on the behavioral health side. So there used to be case management in our system. A couple of years ago, it went away in favor of care coordination, but the care coordination model that's in place today really doesn't provide some of that long-term follow-up and intensity that's needed for these children. That's going to be evolving under the tailored plan, and we can certainly talk about that, at a future time. But so what Cumberland County did in partnership with Alliance and the state is they started something called High Fidelity Wraparound, which is a model that takes a case manager, a family navigator, and it's supposed to engage with children and families and make sure they're getting the services they need and really do everything they can to try to keep the children from having to go into residential care. If they go into residential care, stay involved with them to make sure they're not going kind of right back in. So it's this intensive model of case management, making sure that things are moving along, and it does rely on working with a family. So one of the challenges is we know that all these kids come into care have families to work with. So we developed a new service model that we're calling case coordination with providers who do the high fidelity wraparound. So even if the child doesn't have an identified family to work with, they'll still be able to get this kind of longitudinal case management, where you have one provider who'll be following up and following kids through different levels of care. So that just started up in February. And primarily the provider in the area doing that is youth villages. And they do some of this nationwide. So another one of the challenges that was identified in our meetings with the Department of Social Services is that at the time of a crisis, if the department or if a foster family doesn't necessarily want to take a child to emergency department for care, and it's an after-hours kind of crisis, the mobile crisis response time that's required by the state really is not sufficient to meet the needs of these children. So there's a definition in the Medicaid and state service array that's called mobile crisis management. The requirement is a 2-hour response time, and unfortunately, when we look at it, that's about what it takes to get coverage throughout our 4 catchment area. It can take about 2 hours, and I think you realize if you're having a crisis, 2 hours is too long to wait. So what our team did is I looked at other models that were specifically developed for kids, and we were able to find a model that was implemented out in the western part of the state called Mobile Outreach Response Engagement Stabilization, or MORS. And the idea is that you would contract with a more localized provider. They'd have to guarantee a 45-minute response time. Again, ideally it'd be kind of more real time, but they are responsible to have 24/7 telephonic coverage. So if someone calls in a crisis, they would be able to get someone in real time to talk, and then staff is supposed to be dispatched to the location within 45 minutes. And the other nice thing about this service, unlike mobile crisis, which really addresses a crisis for maybe at one session, maybe one follow-up during the week, this actually allows the provider who kind of engage with the family, and it could be a therapeutic foster family or a foster care family, to stay engaged with that youth and family for 8 weeks. So oftentimes in our system, if you have someone who shows up in a crisis, they're referred to another community provider for the treatment, and there's a chance for someone to get lost. So the idea is sometimes a crisis is a good time to really engage families, and they start a relationship with somebody. This model allows the person to kind of maintain that relationship. So if someone shows up at their house at midnight to help diffuse a crisis, they can now stay and work with that family for 8 more weeks until things are more stabilized, and do maybe a more thoughtful transition to another provider for more longer-term support. So we are looking to get that up and running within the next 6 to 8 weeks. There's a provider in the community, Communicare, who has started doing something like this, or preparing to do something like this with the juvenile justice population. So they'll have the infrastructure, they're local, they know the community, and so they'll be contracted to do this service. And as it gets closer, we'll begin to talk about how to make referrals, start sharing phone numbers, and things such as that. So before I go to kind of the residential spectrum, any just questions on what I've reviewed so far? All right, I'm going to keep rolling. So the other challenge that we heard loud and clear was that there was a need for an immediate stabilization option for some of these youth that they really have behavioral health challenges. They're not at a level that maybe necessitates them being in an inpatient treatment center, and what ends up happening is children could be seen at an emergency department and stay there for kind of inappropriate lengths of stay, or they may be in the DSS-run group home, which really is not set up for kind of to manage children with kind of more intense behavioral health needs. They do, but it's really not the design of that program. And that also can create a lot of disruption for the other kids there who are there and not having those kind of issues. And we tried in the past to do some things using therapeutic foster care. I think the issue that the profile is children with more aggressive behavior, the tendency to potentially run away, made it that they really needed a placement that needed more awake staff. And we began going down some different roads. We initially proposed a contract with a provider out of Charlotte that has a campus, and they were going to set up a program specifically for kids in Cumberland County. And we acknowledge it was a problem. The distance is far getting kids to Charlotte. It really disconnects children. The idea of these programs, they're not kind of longer term. So the further away they are, the harder it is to really reunify children to the community. So after some conversation and some work with the county, an option was presented that there's a local group home that could be used for this purpose, repurposed. So 6-bed group home, I believe it's called the Right Track group home. So what we did is, looking at the needs of the community, we decided to kind of go forward with both options. So we are going to work to open a 6-bed crisis group home in Cumberland County in Fayetteville that has 24/7 supervision, awake staff. Children can go and they should be able to be referred and admitted within 4 to 6 hours of need. So we're not waiting days to find out there's an opening. If there's an open bed, they're expected to take the children into care. That children can stay for 45 to 60 days. And, this is a guideline. If on day 60, there's not the next placement available for the child, children aren't going to be kicked out and returned to an inappropriate placement. But kind of the idea is that really when children go there, we all work together pretty closely to make a good discharge plan. And then hopefully by day 60 or soon after, children can go on to their next level of care. And then we are going to continue to proceed with the program in Charlotte as well, which will provide 8 additional beds. And I think we're setting up that program. It's going to be kind of the highest level of group home management that our system allows. So that's going to be a locked facility. Again, overnight staff, higher staffing ratios. So there may be children that for some reason it's thought locally is not the best option. We'll have a backup. And also you can envision a 6-bed program. These things, ebb and flow. You could have a period where you have 10 kids needing care. And so having that backup facility will be good. Rob, maybe I'll speak a little more of some of the timing of the Cumberland facility. I know we're working with the county to work that out. But we anticipate the facility in Charlotte being able to start taking admissions in May. So Thompson's Family Focus is that provider. They've already actually ordered some of the equipment, installing additional cameras for safety. So that's well on its way. So and I think the last challenge we talked about when we were meeting as a group, and as Rob said, this is kind of a statewide and a nationwide challenge, that there are these children that just the current system is not adequately meeting their needs. I think we'll see this with some older kids. So these are children who might come through this crisis system, go to the crisis group home, and really the current service delivery system is not well set up to meet their needs. We have locked psychiatric treatment facilities. They provide some obvious benefits to these kids, but also they tend to be shorter term, and they get a real mix of children all kind of sometimes put in one facility, which sometimes can create some issues. So they certainly work well for a certain population, but like everything, it doesn't work for everybody. So we looked at this idea of having a longer-term transitional facility where kids could go who have really bounced around the system, whatever levels we've all worked on, whatever treatment plans we've made for them in the past have not seemed to stick. And so the idea, these will be a place where kids could go, get a really much more comprehensive, thorough evaluation, and give really everyone time to look at a longer-term transition plan. And this level of care doesn't exactly exist today. So we're partnering with the other LME MCOs and really going to propose to the state this kind of model of care we'd like to put in place. And one of the things we'd also like in this model is to make sure it has the ability for children to go, but as community options or kind of longer term options are identified, children can go, have kind of trial stays, be able to stay, make sure it's taken without losing their bed at this facility. So it's a different funding model as well, and much more kind of intensive level of clinical support than that's available in most of the current levels of residential care in our system today. Rob, I don't know if you want to add anything to that. I know you've been involved with some of this development as well.
No, we've heard this loud and clear from our stakeholders, the need for, and we've identified the need for a more comprehensive residential program. It should be short-term. It needs to involve the family. The level of care that we're talking about is to meet those kids' needs that sit in EDs or sit in BSS offices with just very severe and complex and trauma-related issues. So we're going to need some support from the state and the General Assembly. So we have brought in other LME MCOs. They're on board, and we're going to be putting forward a proposal soon. And we really hope this is something that will get supported, funded, and approved.
in our kind of sorry.
No, go ahead.
No, so in our vision would be the design that this could be a place where children could come and kind of move through a continuum, so they could come get this very, very intensive structured treatment, and as they're getting kind of ready for discharging, be able to stay and see how they're doing when they have kind of, additional kind of freedoms, responsibility as some of the intensive therapy begins to taper. So they would really have a chance almost, ideally, if you could almost think of a cottage type system where kids could transition, into kind of least restrictive level of care, but they're still in touch with that treatment team who's been working with them and their family and the community the whole time. And I think that's it for the slides. And be happy to answer any questions if you can.
Give folks time to unmute. So,
I was going to ask a question.
go ahead, Crystal.
Rob, on the crisis coming up, that you can do the 15-day stay, are you going to have staff there that will be facilitating the placement?
That is a great question. Sean, you can help me out too. So yes, so anytime child goes out of home placement, we set an expectation on the provider that discharge planning starts immediately. We will most likely have a care coordinator assigned to the child crisis facility helping with that discharge planning. Am I answering your question? That's a good question.
Yes.
I have a quick question. This is Sharon McLeod. Can you give me some feedback in terms of when the 6-bed right track facility will open?
Yeah, let me start on that. So we have a meeting Friday with the county, and Brenda's going to join as well. Dwayne's here, and he can help me out too. So right now we're working out the logistics of moving this facility from a Cumberland DSS facility to a facility that we can use for the purpose we described for the crisis facility. So it is going to require some reno. The facility's in good shape. We were impressed with how good a shape it is. There's a septic issue that I've heard about more than I need to hear about, but other than that, the facility's in great shape. And then we got to get through some reno stuff, get it licensed by the state, and we'll get going. I will tell you, our commitment is to get that going as quickly as we possibly can. Dwayne, anything you want to add that I'm missing?
No, I think you covered it pretty well. I think we'll have a better idea of that after our meeting on Friday.
Yeah, absolutely. Okay, Ms. Glenn, I see you are muted. Did you have a question or comment?
No, actually what happened, I lost my internet, so I had to go.
Oh, okay. Okay, that's no problem.
Sorry, Sean.
Hi, Liz.
So, Bob and Sean has done a great job. Board members, as you know, one of our challenges that really brought this issue to a crisis is that we were really struggling with kids, especially kids that had aggressive behaviors that were at our Safe Landing group home, and were having some real challenges. This work and communication has been in partnership with our new chief district court judge, DJJ, Jason Hunter's been involved, senior staff at Cape Fear Valley Hospital, Alliance, and DSS. And thank you, Rob and Sean. They've really listened to us and really sprung into action in trying to address these needs. I did want to give Victor Armstrong, the State Division of Mental Health Director, an opportunity to make any comments. There's been some great things that the North Carolina Department of Health and Human Services have also put in place to help counties, especially when we have those situations where we have a child that has those kinds of chronic needs and we're sitting at the office or they're in an inappropriate placement, to try to address those immediate needs. And so, Victor, I didn't know if you want to share a little bit in terms of what DSS is also doing at the state level to help address this need.
Sure, and I know I have shared a little bit of this with this group before, but so a couple of things. First, Brendan, thank you for inviting me to the meeting, and then absolutely for giving me a chance to have anything to say. I want to thank Rob and Sean not only for their presentation, but for the work that they're doing at Alliance. And I would be remiss if I didn't say that the kind of collaboration that I see between Alliance and the counties in the catchment area, not least of all Cumberland County, does make my job at the division a whole lot easier, because a lot of what we end up doing oftentimes, and in part what we're doing with the kids that are getting stuck in hospital EDs and sometimes the DSS offices, is we are utilizing resources at the department level, DHHS level, to bring together folk from Division of Mental Health, from Medicaid, and from my DSS folks at the state level, to triage some of these cases and to try to help figure out, more often than not, creative ways that we can address the needs. And what we are trying to encourage LME MCOs and communities to collaborate on is exactly what we see you all doing here today. And that is trying to be forward thinking and trying to create resources for the kids that we know have issues, and trying to figure out how do we get upstream and at some point break the cycle of just turning kids in and out of settings and utilizing resources that don't meet the child's need, and trying to figure out how do we do a better job of serving these kids. So I commend you all for the work that you're doing. We did start back in December with utilizing our teams. We put together 3 teams at the department level. We have what we call our rapid response team, which it consists of some of our assistant directors at the department, from DSS, from the Division of Mental Health, and from Medicaid, who will staff cases on a daily basis. These are cases that are referred to them by local county DSS agencies, where they have kids that are either stuck in hospital emergency departments. Oftentimes, they are kids that may be living in a DSS office or in a hotel room because we don't have a suitable placement for them to go to. And so that rapid response team gets involved, takes a look at the cases, tries to bring the DSS folks and the MCO folks together to really talk about what the options are, to look at resources, to figure out their creative ways to do things. Oftentimes we're talking about things like trying to put together those high fidelity wraparound services that Alliance is proactively putting together. Since December, we've staffed 34 cases of kids ranging in ages from 6 to 17 to date. We have helped to secure either temporary or permanent placement for 26 of those. We have 8 cases that are active now that we're still working on. I think we've only had 1 from Cumberland. That one we are continuing to work on. And I think we've been working on that one now for maybe about 3 weeks. But we're continuing to work through that one and trying to figure out what's going to be the best course of action for that child. A couple of things just really quickly that we have learned to this point. Is that we see that there are some challenges that have been highlighted as kind of long-standing issues. One is that there's often a lack of consensus on short and long-term placement solutions for children across agencies. We have situations where there's disagreement between some of the MCOs across the state and their local DSS organizations on what the best course of action is, who owns that process, whose responsibility it is to solve it. Not a problem that we see here with with the collaboration that you all have here. We also see that there's a lack oftentimes of shared and longitudinal IT infrastructure to track consumers. And those are things that we've got to work out internally to figure out where the resources are at any given time across the state. That's one thing that we as a state have not done a good job of, is knowing where resources are that fit the kids at any given time, so that we can move kids into those resources. And then, the third thing is just the communication oftentimes across multiple providers, whether it's the LME MCOs and local DSS agencies, or sometimes the provider agencies, and understanding if for example, we are trying to place a child at a PRTF, And sometimes I can talk to an MCO and they may say, we've had 20 PRTFs to turn this child down, but they don't necessarily know why. And if I ask, well, you know, what did you ask any of the PRTFs what it would take to get to a yes as opposed to a no? Could you wrap services around? Could you do something different? Oftentimes those kinds of things have not been tried. So we try to work through those kinds of things with our LME MCOs and with the partnership of our DSS agencies who are helping us to better understand where some of the pain points are that the DSS organizations experience. But I will say that I think more collaboration like what we see here, where you have the LME MCO and stakeholders coming together to talk about and be on the same page about what the concerns are, and then talk about the ways that you are going to mitigate those concerns are exactly what we need to see more of across the state. So Rob and Sean, I commend you. Brenda and your team, I commend you. And the board members and leaders from the community, I commend you as well for the work that you're doing. So again, thank you for giving me a few minutes, and I appreciate what you do. And Brenda, you know, you've got my number if you need me, and I appreciate you talking about how responsive I am, but I have learned not to say no to you. So you don't get a lot of options.
Oh, Victor, you've been wonderful and very responsive, and
Thank you.
just commend both our everyone from our representatives, Cumberland County representatives on the board, Ms. Gloster, Dwayne Holden, Commissioner Adams, our county commissioners, our county manager, but also Alliance, but also the Social Services Board. Our Social Services Board is an active and engaged board. They keep their pulse on what's happening in our community, and they are not afraid to speak up. So I want to thank our board for going on the record. I didn't invite you. I was the vehicle. The board asked, DSS board asked, Social Services Board asked that you come today because they want to know what's going on, and they are solution focused, and they want to be at the table around those solutions. So I want to commend our board members for being engaged and being involved. And Victor, I think you're right. I mean, we can bump heads, can't we, Rob? But at the end of the day, we are about solutions and how to best serve our citizens. And we all have the same ultimate goal. It's about quality service delivery to make the lives and improve the lives of the children that we serve. But I would be remiss in saying that we also have to have similar focus for our disabled adults and our adults that we're finding in these same chronic situations. So one of the things that the work group that we have, we've established, our work group is being led by Cape Fear Valley Hospital, and all of us have representatives on that work group, Alliance to Court System. This is really not a DJJ issue. And so we're meeting, I think next month, Rob, we're meeting again. And that group is kind of a springboard of our quarterly meetings, and to restart also because we don't want to neglect our elderly and disabled adults that we're seeing with these same similar type of chronic crisis. And so there's a lot more work to do, and we certainly look forward to the continued partnerships. I'll stop there and see if any of the Social Services Board members have any questions or comments.
I do, Brenda. Can you hear me?
Absolutely, Betsy. You might want to introduce yourself to the group.
I will. I'm Betsy Bradshaw, and I'm on the Cumberland County DSS Board. And I just wanted to say thank you to all of you for your input and explanations of what these proposed solutions are. The problems with the children in Cumberland County has really been concerning, and as a board member and a citizen of Cumberland County, particularly when I work with them with health issues, it has been quite alarming, actually. That's one of the reasons why I wanted to participate with the board at DSS, was to see what goes on from the other side. I'm the one that sees them from the nursing medical side, but I thank you for your explanations, and you've really clarified a lot for me. And Brenda, thank you too for all of the written comments that you have given me as well. I kind of hate to ask this because I know everyone wants to leave, but I'm a detailed person and I don't expect a lot of detail, but I just want to make sure that I am clear with what the process is for the child when we get the first call that there is a crisis. And what happens when the child, or if the child is taken to Cape Fear Valley or a local hospital. I've also been involved with the Cape Fear Valley side of it, the Cape Fear Valley Medical Center side. And it does cause quite a strain on that system as well. So if someone wouldn't mind just giving me a couple of minutes spiel from the original contact that we have a crisis through as much resolution as possible. What is the proposed plan? What do we do?
John, you want me to start and you fill in?
Sure.
All right, you can correct all the things I don't say right, but I want to make sure I get this right for Betsy. So Betsy, when you identify someone, the child in need, there's a couple of things you can do. They can go directly to one of our providers, right? They can go to, when the child crisis facility, if the child's in crisis, they can go directly to child crisis. The other option is
So as a lay person out there, how would I know where that crisis person is? How would I know how to contact that person?
So, great question. So if you don't know what the resources are, we have a 24-hour call center that you can call. You will get a live person each time you call. They will take some information. A couple things they'll do a screening, kind of identify what the issues are. They can either, if the child's in crisis, they can tell you about the crisis options, right? They can either tell you where the crisis facility is, or we can deploy mobile crisis to go to that child and family. Or if they have a provider, they can contact the provider and make that connection, and the provider can help that person get connected, right? So the other thing that may happen during the course of that, if it's a known person to us, our care coordinator will get involved, and the call center will help that care coordinator get involved, and they will help assist making sure the person gets to the right place as well. So that if all else fails, call our call center, and they'll either get referred or they'll help you dispatch crisis services to get that person's needs met immediately. Sean, anything you want to add to that I missed?
Yeah, just the other thing too, that if you call the call center, they actually will call you back. So if they'll check in to see if like the crisis service showed up within, so let's say it's the mobile crisis, they'll actually check to make sure the person got out there, was seen. And if not, they'll call, make follow-ups until there is some resolution. If the suggestion is to have the person put on an involuntary commitment, they actually will call the facility, give them a heads up someone's coming, and they'll help just kind of keep people in the loop to make sure something happened for that crisis. So that's just the only thing I'd add to that.
How frequently? Go ahead.
Yes, I was going to say, I just emailed the board members. I just emailed you the link to all the crisis information for Alliance, including their crisis line. I just sent you that.
Right. Thank you. So how often are the children and adults, as Brenda mentioned, how often are they taken to the hospital versus another facility? What proportion, what percentage of these calls actually go to the medical centers? Do we know?
John, do you know the answer to that?
So what I'd say is that when people call us, and I don't know the numbers offhand, and we could follow up, but it's when people call us, we're able to redirect them away from the emergency departments. We find most of the people who go to the emergency departments never called us in the first place. So it's a little hard to give you that, but the only time we ever would recommend going to the emergency department if it's kind of like life-threatening, imminent, risk of kind of immediate harm to someone or somebody else. In those cases, we'd actually call the police to go out to those situations first before actually telling someone to bring someone to the hospital. But if you call us, we're really never saying go to the emergency department. It's always we'll call mobile crisis or we talk about the local crisis resources.
Okay.
If I could add, and Sean and Rob, correct me if you think I'm wrong on this one, but also too, lots of time, Betsy, they may present at the hospital actually in crisis, whether it's through law enforcement, emergency services, families take them to the hospital. And the challenge we found sometimes is once they're stabilized in the hospital, say if we have a child that's in crisis at the group home and we take them to the emergency ED, the challenge has been once they're stabilized at the hospital, they may need a higher level of care. And that has been the challenge, then trying to find that higher level of care. And so I think the hospital will say a lot of their challenges once they get the individual, whether it's a child or an adult, stabilized, that next phase of the discharge plan becomes a challenge.
So what is the proposed method of solving this problem?
So a lot of what you heard today in the plan, so one of our goals is to try and divert people, kids and adults with psychiatric from going to the ED as their first stop, right? But there's got to be resources. So you have the adult crisis line coming up, you have the child crisis facility, you have an advanced mobile crisis. We're going to have 2 group homes. There's some other things. We have rapid response home. There's other things that we're going to have to get word out to the community that are going to be available for these folks to prevent ED admissions, right? So again, as Sean said, those should be for the most severe and critical folks, but we've got to have resources in order to divert them. And they're coming, but they're not here yet. They're in the works.
Mm-hmm.
And we do have the work group. What'd you say, Betsy?
I said I appreciate all the hard work that everyone has put into this, and it's very encouraging. And that we're going to have some actions in place and buildings in place and brick and mortar and that type of thing. So thank you.
Okay, Bill, unless there's other questions from the board, we certainly thank Rob and Sean. Dwayne's raising his hand. Dwayne?
Just a 2-minute plug, but
Dwayne?
obviously as a board member, one of our responsibilities is to make sure that we're ensuring, compliance for Alliance and that all of our quality measures are being met. But the other thing that we are really tasked for is advocating on behalf of the organization. And I often find myself as a board member taking the opportunity to make sure whenever I speak that people understand the importance of Alliance being a public organization. Some people think Alliance is a private insurance company. That's not the case. They are a governmental entity. And as such, I think it lends itself better to this type of collaboration and coordination. And quite frankly, the quick responses that you see around trying to meet some of these challenges. So I'm always advocating for retaining the public nature of our LME MCOs. I think publicly managed mental health, IDD, and SUD is critical to our success, and that it's not privatized. So I just wanted to put that plug in there.
Thank you, sir.
And I would also just say to our guests that are here, also Commissioner Charles Evans also serves on the Social Services Board, and he sends his regrets. He had a meeting this afternoon with our legislative delegation. He's also our new chair of our board, so he's assumed some additional responsibilities along with being on the Social Services Board. But he's involved, he's engaged, and he sends his regrets that he couldn't be here this afternoon.
Brenda, if I can, I just want to thank you and your board for inviting me to come, and thank Rob, of course, and Sean for participating. But this sort of start my thinking back when I was at Walker's 5E, and of course dealing with social service. So it's just coming back home. But I do appreciate the work you all are doing, and please know that Dwayne, County Commissioner, and I are really working very hard with Alliance to make sure all those things regretfully, sometimes you have setbacks, but we don't worry about that because we know we're going to complete the task. And I thank you for allowing me to be a part of this, Brenda. And I would like to be maybe invited back to come to some of your meetings, and that would be grateful for, because I know the different times that I, as a principal, had to call you all and let you know that I need help. So you're not out there by yourself, and thank you so much.
Well, we certainly appreciate all of your support. And, again, this has been an effort. And like Victor said, even when we don't agree, we work together and we tried to figure it out, don't we, Rob? And Dwayne and everyone. And so Cumberland County strong. And when we put our minds together, we can move mountains. So thank you, everybody. Again, thank you, board. So Bill, I will turn it back over to you.
Thank you, everyone.
Bill, okay, there you go. Bill, you're talking, but we're not hearing volume.
I just want to thank everyone and really appreciate the information.
Great. All right.
You're not hearing me. That's interesting.
Okay. We can hear you now.
I don't know why.
We can hear you now, Bill. Bill, we can hear you now.
Now?
Yes, we can hear you. Well, you're showing on mute again. We heard you just a minute ago. Answer, can you try to unmute everybody and just see if that'll work? Hold on one second, Bill. We're trying to get your sound. There you go. Your green light's on, Bill. No, we're not hearing Bill. I think we're having some technical difficulties.
Okay, can you hear me now?
Yes.
I'm yeah, I assume you can't hear me now. My lights. Not quite sure what it is. Did you hear that?
I heard you say that. So, Bill, if it's okay, you might want to try to sign off and sign back on. And Kathleen, if you could pick up.
Yeah.
Yes.
Brenda, he may want to mute his computer and then call in by phone.
Yeah.
Well, Brenda, you better go ahead now. I just wanted to thank our guests.
So Kathleen is the vice chair, so I'm going to ask Kathleen if she could facilitate until we can get Bill. Bill, you may want to sign on and sign off and sign back on, and maybe even by your phone. So Kathleen, if you can pick it up as the board vice chair. I think we're at the management report with Renee.
Okay, yeah. Can you hear me?
Yes.
Okay. Yeah, if we can start, Renee, with the management report and the first of our business, please.
Okay, if you could look in your packet, board members, and pull out your performance management report. We will start with the first page, looking at the budget items. Our year-to-date spending for foster care and adoptions, you can note that it's at 37%. And spending for subsidized child care at this point is at 53%. Down at the bottom of the page, you'll note that the turnover rate right now is 2.51%, and that's just up slightly from the month of November. The vacancy rate is 17.74%, And that's up even a smaller little smidgen from November than the turnover rate was. So nothing really notable about the rates increasing or decreasing there. Does anybody have any questions? All right. If not, let's roll into the adult services section. There were not a whole lot of fluctuations in the data page. I did note that the care center it looks like they're increasing the number of appointments slightly, and we're hoping that trend is able to continue. I know they've had some staffing turnover there and people getting trained, so hopefully things are getting on track. Then if you look over, I'm sorry, does anybody have any questions about that one? Okay, if you look at the next page with economic services, the FNS apps and cases as well as the Medicaid apps only have slight fluctuations, starting to get a little bit of a wave pattern, and that's kind of normal. We did have, see that Medicaid cases have been steadily increasing, and we had 1,118 more in December than we had in November. It made me kind of start thinking about it, so I went and researched through some of the data I had. I went back as far as 2013, and for the first time since at least 2013, we have gotten over 80,000 Medicaid cases open. That's not happened before in recent history. So that's a significant thing. We see people are in a lot more need and are coming to us, and we're able to open cases for them and provide services. Another thing to note on this page, if you look down at the bottom at the subsidized child care for the month of November, which would be, they're always another month behind whatever we're reporting. We were not able to get the number of children served, so the information is becoming sporadic again. Just wanted to make that note and let you know we're trying to track it, and we'll report it whenever we can, whenever we get that information. But for the month of November, they did not give us a number of children served. Any questions on that data?
Yeah, Renee, why is that? What is the holdup with that?
I think that it has a lot to do with the way that they were paying providers for a while during the worst part of the crisis, the pandemic, and they do some projections, and now I think they're still trying to clean that up some. So I'm hopeful that for the month of January, we will be able to have numbers, and I'm hoping it will be continuous from then on, but they go back and they have to make corrections, and sometimes when they have a lot of corrections, they don't get the information to us very quickly.
Okay.
Any other questions? Okay, if you'll turn onto the back page, we'll look at children's services. And the things of note here, we have the total number of children that are 0 to 17 that are in care. We have 807. The youth that are 18 to 21, we have 57. And then for the total children and youth receiving services, we had 864. And I won't read through the rest. You can look through those yourselves, but there's not a lot of fluctuation here. We're still lower in categories than we were at this time last year in most categories. Do you have any questions for me?
I'm sorry, Renee. I just want to tap the reduced number of kids in foster care. We haven't really celebrated that, and hopefully next month we could spend some time celebrating it. Board members, if you remember, almost 4 or 5 years ago, we were pushing close to 1,000 kids in care. We were at 183, 84, very close to that 1,000 number, and kind of stayed between that 930 and that 960. And when you look at 807 kids in care, I don't count 57 because the age 18 to 21 is new legislation. But that is a significant decrease in the number of kids in foster care. That has to do with a lot of the work that we've done with our court system, DJJ, with our AMAC project. And so we certainly next month want to really celebrate and talk about the reduced number of kids that we have in foster care. It is worth celebrating, and a lot of good work that has been, went on with that. And so we hope to share that next month.
Brenda, can you hear me now?
Yes, we can.
Okay.
Do you have any questions about the children's services?
Okay. Okay, thank you, Renee. You have anything else?
No, if nobody has questions, I am all done with my report. Thank you.
Okay, if we don't have any questions, then we'll move on to the next agenda item, which is economic services.
That would be me, Bill. How are you?
How you
Good
doing? I'm
afternoon,
fine.
everyone. I want to give a brief update on our energy assistance program. First of all, let me just say that we've had some possible confusion. There are actually two very distinct programs in the energy programs, and those are the Crisis Intervention Program, some of you know of as SIP, and the Low Income Energy Assistance Program, which is we call our LEAP or LIHEAP program. First, the SIP program, it is a federally funded program designed to assist individuals and families who are experiencing a heating or cooling crisis. This program funding starts each state fiscal year. That's July the 1st to June 30th, or until we exhaust these funds. The maximum benefit amount allowed per state fiscal year for the SIP program is $600. Under this program, we do not pay water or sewer expenses. The LEAP program, or the Low Income Energy Assistance Program, this is a one-time annual energy supplemental program. It's not tied to a crisis, but it's to help families pay their heating expenses. Many times families will come in and the caseworker will do an assessment, and if they're actually in crisis, the program that we would start with first as an application would be the SIP program, because it's tied to a crisis. LEAP runs December 1st through March 31st, or until the funds are exhausted. The other thing about LEAP is the month of December is solely dedicated to our senior population. With COVID-19, of course, that presented a lot of challenges for us, and the Department of Health and Human Services provided the following guidance to support counties at this time. There was a pandemic automatic payments were issued for eligible seniors and people with disabilities who received LEAP and are food stamp recipients last year. If they received food stamps or received LEAP last year, they automatically got an issuance, what we call a pandemic automatic payment. All other households would have to apply for LEAP, and that would be January through March 31st. Our benefits would be paid directly to the energy vendors for LEAP based on the household size and income. And that could be a $300, a $400, or $500 payment. Our LEAP customers, and let me go back, our SIP customers, once we determine that they are eligible for the SIP program, the caseworker calls the provider and pledges that we are pledging that they are eligible and we're going to be sending a check for the amount. On the other hand, with LEAP, our customers are advised that once approved, it could take 6 to 8 weeks before the account is updated by their utility provider. And we always say to them, if you have further questions or concerns, direct them to your utility provider, because at that time we cannot do anything with their account. I also want the board to be apprised that we recently were contacted by the Fayetteville Observer, a Fayetteville Observer watchdog reporter, who has expressed concerns from someone, I think it was 2 people, who received an approval letter for LEAP and still had their electric bill cut off. What we need to remember is that this program is not for a crisis, but it's there as if they have an immediate need, they would need to apply for SIP. So therefore, this year, these individuals, they could apply for SIP, and if they did not have an immediate need and their lights were cut off, they would need to contact their utility provider again. I also like to reiterate that the LEAP program is a one-time annual supplemental program. It's just like, when we get our tax refunds, or some people have gotten different types of supplemental checks. You don't know when it's going to come. You really don't want to bank on it and think that that is going to pay your current light bill, because you don't know when it's coming. And LEAP is the same way. It's a supplemental program that can take up to 6 to 8 weeks before the account is updated by our utility provider. We here at DSS have no control over this. It's the customer's responsibility to contact their utility provider to clear up any discrepancies or concerns. I don't know if the reporter possibly will be doing a press release, and I don't know in what nature it will be, but we here at DSS have worked very diligently and have had very, very few complaints from customers. And I want to say, and just to give kudos to our staff in the energy program, there are actually only 6 permanent staff working there. And in January, because of the volume of applications coming in, we brought in 4 retirees staff to help them. And thus far, from the months of December to present, those staff have did over 4,500 applications. So I have to give kudos to them. We're working hard. Sometimes you may have a glitch here and there. Many times if there's a customer complaint, they come directly to my desk, or we have a very, very new program manager, and her name is Sherry Kinney. Sherry's been with us now in this position for about 2 months. And it's like, I won't say baptism by fire, but she's really worked it out, and she's worked very hard and diligently with the energy staff. And I want to say thanks to her, to Sherry, and thanks to other staff that supported her during this endeavor. Vanessa McLean Gray, one of our other program managers, and trying to think of one of our supervisors have also been busy helping out. But we've done over 4,500 cases, and if we're just getting 2 or 3 that may have had a problem, And anytime there is a problem, we resolve it or we give feedback. And I think the biggest thing that we have to continue to do is to educate our customers on what is available, how to apply, and what some of the program policies are. But again, I don't know what may come of this report. We've met, Brenda, myself, and Sherry met with her for about 2 hours, about 2 weeks ago. And there's still a lot of problems and concerns. And we will continue to address those concerns as they become available to us.
So board members, I think Vivian's done an excellent job of capturing the issues and concerns. And we do believe, and we do have some concerns that citizens and maybe intertwining the processes and procedures for SIP and LEAP, and they are very different. And so I wanted to make sure that Vivian shared with you what the concerns are. The complaints have been minuscule. And it's very, very important that any citizen that has a cutoff notice, that they first certainly contact their utility company and let them know what services that they may be received through LEAP, but also apply for our crisis intervention program. And if they're not eligible for the program or they've already exhausted the funds for those programs, then, we will try to refer them to community agencies that may be able to assist. And so thank you, Vivian. She spent an awful lot of time addressing this media issue. And we did have, 4 or 5 cars a couple of weeks ago drive through the parking lot, honking their horns, concerned. There was a bit of confusion. There is, and I think Dwayne may have hopped off the call. There's a little bit of confusion about the COVID relief funds around relief rental assistance. And so there are some federal dollars for rental assistance and utility assistance that have been allocated to the city and the county. Those funds are being managed at that level. And there has been a request for proposals to look at a contract vendor to administer those programs. And so the city and the county are working together. Because that's a fairly new program, fairly new resources that have to be built out, and that takes some time. So there seemed to be some concerns and maybe some misunderstanding that those funds were readily available and ready to distribute, and that's not the case. So.
Yeah, Vivian, I want you to know that the board really appreciates how hard you and your staff have worked. And you know that I especially know just how difficult those programs are to manage.
Yes, I do.
Okay. Any other board members have any comments for Vivian? Okay, if not, moving on to legal. I assume Bobby's going to make the introductions? Or are you going to do that, Brenda?
No, Bobby, you're doing it, I'm doing it. Bobby, you're doing it?
Brenda's doing it, I think. Let's have Brenda do it.
Okay, I got it. Look, Patrick said he don't care as long as one of us do it, right? It's an honor.
Always trying to get it straight.
That's right. It's my great honor to introduce to you board members Patrick Kuchit. Patrick, wave your hand. He has on the white shirt with the tie. There he is. Patrick is a smart and bright young attorney. We were fortunate to be able to grab him as a attorney for children's services, and he's been working with us 2 or 3 years as a staff attorney, doing a fantastic job, primarily assigned to Judge Siler Mack's court. And every time I see her, the first thing she tells me is, "Don't move Patrick out of my courtroom." And he's done a lot of with DJJ and working very closely with that sector. As you know, we've had a rich history at one time of a lot of delinquent kids coming in our care, and we've done a lot of work with DJJ partner, and Patrick's been in that courtroom educating the attorneys and the district attorney's office around those issues and staff, and has really helped to make a difference in the number of those delinquent kids coming in our care. Patrick has been promoted to our new Assistant Director of Legal Services. Patrick has a degree from Campbell University. He's a retired military person. He served in the Air Force. He's had experience in private law. He's worked at the federal level in different capacities, federal court level. He is loved by the section and certainly by Children's Services as well. Patrick is one of those folks. He has the calmest demeanor of anyone you will ever meet. And he has a pleasant attitude and is just an absolute joy to work with. Take charge kind of person. Don't misunderstand that demeanor. He's tough and he's decisive. He's thorough. But he does it with the utmost professionalism. And we're just excited to have Patrick and leading that team. You should have heard the cheers in the agency when we announced as that having that job. That just showed that he certainly have made a impact and a positive impact with the staff here at DSS. So his head is as big as his office now with all those kudo things. But Patrick, I didn't know if you wanted to say a few words, but he'll be coming to our board meeting. So Patrick, I don't know if you want to say a few words.
Well, thank you, Ms. Jackson, for what may be the best introduction I've ever had in my entire life. I greatly appreciate the kind words. I'm very excited to be in this role, and I'm excited to learn from Bobby and kind of pick on her years of knowledge that she had doing this role, and continue to work with the department and try and get the best legal section that we can have, and basically just educating who I can about what we do and streamlining any processes that we have. And I'm really looking forward to working with everyone and basically being whatever resource I can for everyone in the department as well as on the board. So I look forward to working with everybody.
Okay, Patrick,
And I was going to say, Bill, if I could, want to give kudos to Bobby Redding for coming back out of retirement to help us part-time, and she's committed to stay on board as long as Patrick feels like he needs her, and as long as she don't have, COVID lifts and she's going off jet setting somewhere, she's agreed to stay on board and to help Patrick with the position, as well as want to give big time kudos to Chris Carr. He helped us with the interview process, also extended his services. As you know, Chris was promoted over to an assistant county attorney, but he certainly has also been very supportive of Patrick and helped us with the solution process.
I just wanted to say welcome aboard, Patrick, and I'm sure you won't mind having Bobby available as a resource from time to time. And from everything that Brenda said, I'm sure you're well qualified to fill her big shoes.
Thank you very much. I'm looking forward to it.
Any other board members have comments?
Yes, I'd just like to say welcome aboard. Patrick and Bobby, thank you so much for your assistance. It's been nice seeing you on these screens the last couple of months.
Thank you.
Okay, if there are no other comments, we'll move on to the director's report.
And board members, in terms of legislative updates, the North Carolina General Assembly is back in session. I haven't seen any major bills. As you know, due to the election, there were a lot of new legislators, and so a lot of the work has been spent, establishing committees and those kinds of things. And so I'm not hearing of any major legislation happening yet. This is a long session, which means they could be in session until when? It could be past July into the fall, because this is a long session. And so as we hear about legislations and bills coming down the pipe, I will I'll let you know. The North Directors Association and the North Carolina Boards Association, in which you are members of, I chair that advocacy committee for what they call the Social Services Consortium that makes up those two associations. We're in the process of, one of our charges is to develop the legislative agenda for your consortium. And so we're in the process of putting the finishing touches on that. And once it's finished, I will make sure that you get a copy of what the focus of the Social Services Consortium will be as we work with the General Assembly in their session. That's really all I have around the legislative updates. As it relates to the county's priorities, I thought it was important to share that. You may have seen it in the newspaper, but I did include a copy of the press release in your packet. Just letting you know what the county's priorities. As you know, our very own board member, Commissioner Evans, is also chair of the Board of Commissioners, and they had a work session last Friday and hammered out their priorities for the next year and coming years. You will notice that some of the things related to social services will, of course, will be homelessness. We certainly will be working on improving government communication. We're really excited that the county now has their own television channel, and we're actually broadcasting live on Cumberland County TV, CCTV, and excited about that. And we'll try to certainly get as many social services information out through that venue as we can. There were also some things that didn't make the official list, but that was discussed related to social services. So some of the things that we will certainly be working with Dwayne and county management on is how we can better partner with our other human services agencies like public health. We're already partnering with them on, they're doing our court order drug testing. Before COVID, Vivian was working with their team to have co-location of WIC here at social services, and just anywhere that we can support and help each other. We do that anyway, but certainly want to enhance that. I've been working with community development, sharing information about our energy assistance program as they try to ramp up the rental assistance program. And so we'll continue to support one another and make sure that county departments are working better together. And so just want to make sure that you had that information as it relates to the county's priorities. Other than that, as far as just general information, we are still closed to the public as it relates to COVID-19, and we still have a large percentage of staff working from home. And we being the management team, we are really trying to determine what the new norm looks like. We believe that at some point we will be returning to being open to the public, but we have had some opportunities with COVID to learn that working from home does work and performance has been good. And so management team, what we're working on now is what does the new operation looks like after COVID. So we're working closely with that, and we're working closely with our public health department. Social services falls under group 3, especially for frontline staff like child protective services, adult protective services, drivers, group homes, domestic violence shelters, serve as frontline essential. And so we have started the process of working with public health, and they've been fantastic and doing a great job on testing and vaccinations, and big kudos to our partners over at public health. But we're also working with them in terms of ensuring that under the group 3 process related to how to get DSS as essential employees and those that are frontline essential vaccinations. And so they've been wonderful to work with there. We also still have staff helping with contact tracing. Anywhere we can support our business operation folks, we've got golf carts over helping. Anything that we can do to support our sister agency over at public health as they do the work that they're doing to protect citizens from COVID and the testing and the vaccinations and those kinds of things. So we're still very much working very differently in this COVID environment, but so far it's working well. And as Vivian said, we're getting very few complaints about being closed to the public, and those that we are getting complaints from, we are trying to address them as quickly as possible. That's all I had for the director's report.
Okay, thank you. That concludes the regular business. At this time, I'll entertain a motion that we go into closed session.
I make the motion we go into closed session.
Okay, we have a motion. Do I hear a second?
Second.
It's been moved and seconded that we go into closed session. All in favor, say aye.
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 Are there any opposed? Okay, we are moving into closed session. Thank you all very much.
So,